There you go. All right. Good evening, everyone, and thank you for joining this webinar with our speakers coming from around the globe this evening. It's a webinar that was first put together by Professor Francesco Bellucci, and of course Francesco is with us this evening, Professor of Health Economics at the University of Newcastle. The unique feature of tonight's webinar is that we're drawing upon our audiences globally, as well as the connections between Australia and Singapore in terms of the University of Newcastle. So I'm the CEO and Pro-Vice Chancellor of Newcastle Australia Institute of Higher Education, and we've been in Singapore for 16 years. And we're a fully owned entity of the University of Newcastle. Tonight's webinar is interesting timing because, you know, we're in the middle of the next battle in the long war with COVID, with the new variant just been uncovered and causing quite a deal of havoc worldwide in the last 2 or 3 days. And I know one of our speakers this evening, our key speaker, is coming from Israel, and of course Israel is at the forefront of the new restrictions, having closed its borders to all international travellers other than citizens and permanent residents of Israel. I personally have come to Australia on a vaccinated travel lane, arrived in Saturday, and now find myself in quarantine. So Australia has reimposed a hotel quarantine. So we, as I say, we're doing this webinar in very interesting times. I just really wanted to also make special mention to what we are doing in Singapore. Currently, we have 10 programs in Singapore, 10 academic programs, but next year, as part of our journey towards what we call the private education institution, we're going to be delivering 6 new innovative programs. And one of these, the long-awaited Master of Health Economics Management and Policy. And I know Professor Francesco Bellucci has driven that program from the start. It's been a very, very successful program in Australia, and we're looking forward to bringing it to Singapore next year. So that's probably all I would like to say in terms of my introduction. I'd like to now hand over to Professor Francesco Bellucci.
Thank you so much, Professor Vallone, and welcome everybody to this joint webinar. And really thank you all for being here. As you come in, I'll try to manage some of the people going in the waiting rooms, as well as the ones that are joining in the attendees directly. First of all, before I go into the presentation, some housing matters. For those who have questions that are urgent, please just write a big U in front of a Q so that I know it's something that it's extremely important to deal immediately, and we'll try to address the matter in the conversation. Otherwise, please just write in the Q&A boxes or chat your questions as a queue, and we'll deal with it as part of the debate that will follow the presentation and the panel discussions. So I'm delighted and honored to have a great panel tonight with our keynote, Professor Prof Glazer. Jakob, I think, is in Tel Aviv at the moment, and one of the many surprised international travelers, and in fact taking this call from Israel, not the UK. If you want, you can tell us all that. But really, the last few days, as Tony has advised, have again revolutionized international travel. And tonight, we are here to discuss digital health and remote medicine, with an economics perspective, but also a practical and a business perspective with our panelists. Jakob has received his PhD in economics from the Kellogg School of Management in Northwestern University, and he has been a professor and a great contributor to health economics in many fields and areas, from insurance to regulation of insurance market to more recently issues that have to do, in fact, with digital health and remote medicine, which is part of a new research agenda. So I'd like to welcome Jakob, or Jakob. You will correct all my mispronunciations. And the second panelist of today is Joan Lowe, who's connected with us from Spain. So thank you, Joan, for joining us tonight. She comes from a banking background, and from managing portfolios, she moved into, I would say, managing new health solutions. She is the CEO and founder of ThoughtFull, which is a digital mental health startup that aims to make mental health wellness solutions affordable and accessible. She's normally based in Singapore, so welcome, Joan. Thank you so much for being with us tonight. Finally, Professor Jeremy Lim. Jeremy is also based in Singapore. He will join us as well tonight, and he's one of the co-founders and CEO of Amili, which is the first dedicated gut microbiome full-service company in Southeast Asia. He also directs and leads the Leadership Institute for Global Health Transformation, LIGHT, at the NUS Saucy Ox School of Public Health, where he works to enhance cooperation, capacity building, and knowledge sharing across the region. So welcome, everybody. And Jakob, please, I leave the floor to you. Looking forward to your presentation.
Okay, thank you very much. Thanks for inviting me, and I'm really looking forward to hear your comments. Even though I'm the keynote speaker, as you'll see, it's not going to be a typical keynote speak, because I'm going to raise more questions than answers, because I think, at least from the economic perspective of what I call remote medicine, there are a lot of questions that actually I think have not been discussed enough, and at least I haven't seen good answers in some sense. I'm looking forward for the discussion. As Francesco mentioned, I'm currently based in Tel Aviv. I have two positions, one in Tel Aviv University at the business school, and the other one in the UK at Warwick University, the economics department. I do teach, I do research and teach and do consulting in health economics for many, many years with colleagues all over the world. And also here in Tel Aviv, I was for many years the head of the health management program, which is something similar to what you have, which is an MBA program for health management. So, and the topic today is really something that I've chosen in a sense to work on in my recent years in terms of research, because I think it's a huge revolution. It started before the COVID, but definitely the COVID gave it a huge push. And in my view, at least, what I call remote medicine will completely change the way we provide or the way we receive healthcare. So let me share my slides. I hope I can. Can you see my slides?
Yes.
Okay. Perfect.
Yeah, great.
Okay. So as I say, the title is The Economics of Remote Medicine, and this is important because remote medicine has a lot of aspects. It has, of course, clinical aspects and ethical aspects and legal aspects and technological aspects, but my focus will be more on the economics. And let me first say what I mean by remote medicine, because I think it's much more than just digital health. I think digital health is just one aspect of it. So the way I view remote medicine is as a range of solutions for healthcare provider-patient interactions that occur outside of the in-person visit. So here are some examples of what we mean by remote medicine, or what I mean at least. For example, that you provide information to a patient over the internet without even seeing the patient, or some platforms where there is an interaction between a patient and a provider, and not in the same, and they don't sit in the same office or in the same clinic. Sometimes even this interaction is not with a doctor, is maybe with some technology that provide answers to some questions. There is also emails exchange between doctors and patients. There is text, messages, text-based messages like WhatsApp and things like this. Of course, there is now what we call telemedicine by phone or video, where you talk to your doctor over the phone or in some kind of a video conference. And of course, there is home hospitalization, which is another way of providing what I call remote medicine. Now, this is, we see more and more of this, and as here I just, basically this is a report by McKinsey, which I've seen some time ago. Maybe by now it's already updated, even though they kind of keep updating it. But just see the size of what we call remote medicine. So it's like, now it's like 38 times in volume. The volume now of what we call remote medicine is 38 times bigger than it was, let's say, 2 years ago. And here are some of their conclusions, which is that we are now basically 20%, and I think that's common to many countries. 20% of medicine is provided in one way or another, one form or another of remote medicine. And according to McKinsey, and I think most people will agree, we will see much more of it. It's just the beginning. And there are several reasons. Of course, one is the technological improvements that enable us to do it in a much better way that we could do it 5, 10 years ago. But it's also the psychological barriers that both doctors and patients, and many of them had, and now kind of they got used to it and they are less scared of using these new forms of medicine. And if you look at the investment that we see now in the business world in all forms of remote medicine, then we know that in 5, 10 years, it's going to be much bigger than now. There is a huge investment. And there are different forms and different models of remote models of remote medicine. And we see in different countries, in different systems, there is a lot of variety and a lot of different things going on. Now, there is a lot of advantages, and I'm not going to talk so much about the advantages, more about the challenges, which you will see in a second. But some of the benefits that we get from remote medicine are, first of all, better accessibility. Now, if you are a typical patient, you can see, in a sense, you can see many more doctors because you don't really have to physically go to the clinic. So even if you live in Boston, you can talk to a doctor in Chicago. Or if you live in Coventry, you can talk to a doctor or be seen by a doctor in London. So patients have much more access to doctors. This has a lot of implications, not only that it's more convenient, but we know that accessibility means health in many cases. So if it's easier to see a doctor, in some sense, your health, in a sense, or your treatment can be improved. So that's one thing. The other one is, of course, you have much more choice. As I said before, you could only choose some doctors in your neighborhood because distance was an issue. Now you can choose many, many more doctors. So the choice of providers, and this is true for doctors, it's also true for hospitals, because some hospitals, as we know, provide remote medicine or home hospitalization. So you don't even have to live in the same city with where the hospital is to be treated or to be hospitalized by the hospital. So there is much more choice. And this also means much more competition, because now I'm a hospital in Tel Aviv, say, I compete also with hospitals that are outside of Tel Aviv for patients, and the same is true for doctors, and the same is true for HMOs. I can now, as an HMO, even if I'm located in Philadelphia, I may now accept members outside Philadelphia, so I compete with other HMOs that I didn't used to compete before. So there is much more competition and much more choice. Obviously, availability is much more now because I can see a doctor not only at the regular office hours. You know, doctors can talk to me, or see me, or answer my emails also late at night or early in the morning, or even if they want over the weekend. So I, as a patient, have much more access and much more availability, more hours that I can see doctors and talk to doctors. And obviously, it's also more convenient. I don't have to go to the clinic. I don't have to be hospitalized. And we know that sometimes this was an issue. Some patients chose not to go to the doctor just because it was too much time spending or inconvenient in one way or the other. And also it's true for hospitalization. Some people do not want to be hospitalized in the hospital, but when it comes to home hospitalization, it's obviously much more convenient. And, you know, there is, of course, less hospitals acquired infections, less time you spend waiting in line. And there is one thing which is really important, communication among providers is much better. So even if I'm a doctor and I work in one hospital, I can now, while seeing the patient, I can communicate with doctors, with specialists in some other locations. And this is, you know, as you know, people talk about, you know, aggregation of treatment and continuity of care. Now all of these things becomes much simpler. You know, if you see a patient, if you're a doctor and you see a patient and this patient has, you know, comorbidities and other medical problems, and you want to discuss the case with other doctors, now it has become much, much easier to do. So this is a great advantage. And of course, in some cases, this kind of treatment can be much cheaper. You know, home hospitalization is likely to be cheaper than, you know, being hospitalized in a hospital. And also some other treatments, of course, may become much cheaper. And there is also another advantage of this new form of medical services, which is data can be collected in a different way than it used to be before, because of all the medical records and all, you know, we have all these new technologies that enable us to collect much more data right now. So these are all, you know, some of the advantages, and I'm sure you will mention more. But I would like to talk more about the questions or about the challenges or the issues that come up as side effects, if you want, of this great development. And of course, one of them is something I'm not going to talk about. I'm not going to talk about much because it's really not so much economics. But in some cases, people say you still need to touch the patient in some sense. You still have to see him when he enters the office. You have to feel him. You have to touch him. And obviously, we are going to see less of it. And this may be a problem. But I'll talk more about the economic problems. So the first one is what we call in health economics moral hazard. Namely, patients, since it becomes more available, since the doctors are more available and more accessible, there is going to be a huge increase in the demand. It's very easy to send an email to a doctor by a text message. It's not like going to the clinic. It's also very easy to ask for a video or a telephone conversation with a doctor. And one of the worries and one of the questions that people ask is, how shall we manage demand in this kind of new world? So always in health economics, we always talk about this problem of moral hazard that comes from the idea that since patients don't actually pay for the treatment, which is a good thing, but because they don't pay, there is huge excess demand, okay? And now there's gonna be even more because it's so easy to try and talk to the doctor or to get connected with the doctor one way or the other. So one question is, how will we manage the demand in this kind of world? The other is on the other side, which is the supply side. When people talk about one of the big differences between the healthcare market and any other economic market, and the one thing that people say makes health economics different than almost any other areas in economics is the idea that doctors, so if you want more generally, providers can induce demand. Patient is usually doesn't have enough information. He goes to the doctor, he is worried. He doesn't really know what the problem is, what the solution is, and doctors can induce demand. And if doctors have the incentives to induce demand, they can do it. And there is huge research in health economics that shows that indeed, and it's not only because of economic motives, it could be other motives like reputation, or sometimes just because the doctor believes that this additional test or this additional treatment can help the patient. So doctors induce demand, and now they have another way of inducing demand. Just think about the simple like family doctor. She works in the clinic, or he works in the clinic or in the office, then she goes home, puts the kids to sleep, and then 8 or 9 p.m., she can see more patients now for 2-3 more hours. Or she can use the email to text them or send them messages. So you have, on one hand, it's great. There is more availability, more accessibility. On the other hand, now the doctors, if they are paid for these additional treatments or additional visits, so to speak, or the additional communication with the patient, they can actually induce a lot of additional demand. And we know that in healthcare, this is one of the big inefficiencies in healthcare, which is overuse on the demand side and overuse of the supply side. And one of the issues is exactly how shall we, on one hand, use these new technologies of remote medicine, but how shall we prevent excess supply and excess demand, or inefficient supply and demand? Now, it also enables, and this is a challenge, providers to distort services and to discriminate. And, Francesco and I are members of an organization that talks a lot about risk adjustment. And one of the ideas of risk adjustment is how to create payment schemes that will prevent providers, HMOs, hospitals from selecting against, let's say, unprofitable enrollees, so unprofitable patients. Now, again, because doctors have this new tool that they can use, they can also use it in some ways to select, let's say, more educated patients if they think that these patients are less costly, or more, richer patients because they're more likely to have these new technologies to communicate with the doctor. So basically, you have a new tool to maybe discriminate against some patients and in favor of others. And obviously, this is always an issue in healthcare. And related to it is what we call digital divide. Not all patients have access to internet. Not all patients have access to even, emails. If you think about maybe older patients or some patients with some, mental problems and so on, they don't always have the ability or the availability of using these new technologies. Or even if you think about home hospitalization, not all patients can actually be hospitalized at their home. They may not have, the right place or the right people at home that can take care of them if they are hospitalized at home. So it's not only digital divide, it's divide in many other directions. So this can be even without discrimination, just the availability of using or the ability to use these technologies is not the same. And we may create another form of inequity or inequality in the system, which is something that we are worried about. Another problem, which is true not only for remote medicine, it's true for many other industries. If people work from home, there are no limited hours. There are not given hours in which you work. And I know, at least in Israel, I've talked to many doctors, and they say that the burnout is a big issue because now they are expected to answer all these emails. They are expected to maybe even answer the phone calls. And they, in some sense, are expected to work more hours because they are at home and it's more accessible and so on. So the issue of burnout, which is true in general when we talk about working from home, when it comes to doctors, it's maybe even more because somehow doctors are in some sense are expected to be available or to be accessible more hours in this case. And obviously there is overflow of information. Just think about the typical doctor now, and he has a patient. Think about a family doctor. Now his patient is going to the hospital. His patient is going to see a specialist. He's going to get all this information all the time. Before, and of course, there is something good about it because now the doctor knows exactly what's going on with his patient, maybe at every moment or with every treatment that the patient receives, even if it's remote. But on the other hand, there is the overflow of information that he may receive, and somehow it needs to be managed. And of course, there is an issue of privacy, which is true for remote medicine. More than, if everything was in the office, this was one thing. But now if you treat a patient and he is in one place, you are in another place, and the communication is over the internet or even telephone, issues of privacy may become much more relevant. And also the question of where all this information is stored in some sense. And of course, this is a big issue. And I think there is a question of the division of accountability and burden, because, if you are hospitalized at home, so who is responsible to what? Is it the hospital? Is it the family? And of course, and it's true also for other kind of remote treatment. So if the patient is in one place, the doctor is in another place. So I think there is some kind of issues of who is responsible to what in this case. And I think one of the biggest challenges, which we could talk a lot about, is how to pay doctors, how to pay hospitals, how to pay other providers for these new forms of treatment. Now, this is an issue that comes up in every discussion that I read or hear or follow about remote and digital health, remote medicine and digital health. And just think about, for example, a typical hospital. You know, a patient came to the emergency room and now they decided to hospitalize him. So there was one option, you know, to send him to the department, you know, maybe urology department or whatever, and that's it. Now, suppose the hospital needs to decide whether or not to hospitalize him, but also where. Should it be in the hospital or should it be at home under the responsibility of the hospital? So now the hospital has two options. Now, obviously, the consideration that he will, I mean, some things to consider, of course, is the medical problem, whether it's more appropriate to treat him at home or in the hospital. But obviously, the incentives are now going to play an important role. How is he paid, the hospital, for home hospitalization versus hospitalizing the patient in the hospital? So I call it the multi-marginal margins problem, because now the consideration will be not only the clinical situation or the medical situation, but also the payment. And the same is true for a doctor. Think about a typical doctor. He can invite the patient to the office. He can tell the patient, let's talk over the phone, or let's have a video conference, or just send me an email and I will answer you. Obviously, the decision may be affected by the way the doctor is paid. And again, this is not only this, of course, there are other things that will affect the doctor's decision. I'm not going to say that it's only the economic incentives, but this is definitely going to play an important role. Before, you know, the doctor didn't even have the option. He could only see the patients in the office. Now he can see him, so to speak, in different ways. So the question is how to create incentive schemes that will actually induce the doctor to choose the right treatment, if you want, or the right way of seeing the patient. I think this is a huge challenge. And I must say, even though I've been following the literature on this, I haven't seen much kind of new insights or new ideas about it. So these are the challenges, and I'll stop here, and you know, the floor is yours now. Thank you very much. And by the way, this is an interesting book that I just must recommend that talks about some of these issues that I've just mentioned. And here there is a quote again from this book about the overflow of information and the excess demand that doctors may face in this new world of remote medicine. And I'll stop here. Thanks a lot.
Thank you, Jacob. If you can stop sharing.
Yeah, I will stop.
Beautiful. Thank you so much. Yeah, this was a very interesting presentation. I have to say, a lot of elements to think about, and I would like to start with Joan, who's put some thoughts about these challenges, and she thought about it looking at mental health, which actually adds you know, other opportunities and possibly also different challenges, because it's not certainly something that you know, applies to every individual in the same way, and technology clearly represents and has represented for many years always a potential solution, and at the same time imposes some of the challenges and others compared to what Jacob was describing. So Joan, can you tell us about your work in this area, and what has been your experience, and whether you think there are other particular challenges in particular in your space? Thank you.
Sure. Thanks so much, Francesco. And Jacob, thank you so much for that presentation. I think it was a very good encapsulation of everything that, you know, as a space we're going through right now. Maybe just a very quick introduction. My name is Joan Low, and I'm the founder and CEO for ThoughtFull. We are a digital mental health startup that's based in Singapore. And really our vision is to make access to end-to-end mental health care more accessible and affordable for people. I think one of the things that perhaps I'll just change the angle a little bit. We've just spent the last 20 minutes kind of focusing on the macro perspective of digital health. The plus, the minuses, and kind of the characteristics. I'm going to just start from the micro first and then kind of tie it in. So really how ThoughtFull was started is because there was a very real use case of how it was almost impossible, and until today, to get access to end-to-end care for mental health. This is something I know personally. We have been caregivers for the last 20 years. That's how I switched from finance in Hong Kong to this. And I think it's one of the aspects that is most fragmented in the system. And when I say most fragmented, I mean it in a therapeutic focus. So if you look at things like cancer, diabetes, any other kind of therapeutic area, majority of your treatment as a user that you're going to receive will happen in the medical system. They will happen in a clinic, they will happen in a hospital, and it will be administered by medical doctors. When it comes to mental health care, and this is specifically true here in Asia, what you'll find is that majority of treatment is actually administered outside of this system. Allied health workers, as we call them here, counselors and psychologists, predominantly do not sit in this system of a medical setting. Majority of them are either private practitioners, independent practitioners, and they're kind of fragmented all over the place. They don't even have access to EHRs, so electronic health record systems at scale, which is very different to what you'll see in all the other different kind of specialists, right? So I think the challenge set is quite different in mental health care. There is some infrastructure building that needs to be done. So, creating the plumbing that happens, how are we connecting this very fragmented ecosystem of care providers in mental health? How do we digitize them, standardize them, come up with universal standards of quality? How do we ensure that things are done in a way that's safe and secure, both not just for the user's data and health, but also on the professional side, right? How do we ensure that they are taken care of? And so I think a lot of the work that we do evolves around solving these ecosystem issues in mental health care. It is definitely something that is a work in progress. I'm not going to lie. It's not going to happen overnight. Rome was not built overnight, let's just say. And so I think for us, how we've been going about it is doing it through our one-stop platforms, both on ThoughtFull Chat for users, as well as ThoughtFull Chat Pro for the clinicians. And both have very different I would say value propositions that's needed, right? So on the everyday man on the street, I think even starting to engage with their mental health is something that needs a little bit more convincing than anything else, just because stigma is still an issue here, not just in Asia, actually everywhere, but I think particularly so in Asia, it's it's very magnified. And so through ThoughtFull Chat, we do provide that first port of call for anyone to engage at any point in their mental health journey. They could be more on the preventive side, where it's more focused on wellness, self-driven content, self-monitoring, all of those things. Or it could, slowly escalate into the curative aspects. Do they need one-on-one behavioral coaching? Do they need therapy? Do they need, perhaps even pharmacological access? All of these things are, things that we're mapping out so that it's seamless. And on the flip side of that, I think to make something seamless, you need the piping and the infrastructure for it to happen. And so that's where ThoughtFull Chat Pro comes in. We are digitizing the largest network of mental health professionals in the region. And I think there's a lot of work that's going into making sure that there is a universal, kind of standards of care delivery. And it's really a means for them to digitize their practice at scale. So yeah, I'll just stop here. If there are any other questions, yeah.
Thank you, Joan. This is a perfect place to pick it up because, and I would like to go to Jeremy on this. So if we think about this, it's clear now, as it is for many things in healthcare, that there is hardly any one size fitting all, right? So we can't really treat this incredible revolution, as Jacob discussed, easily with uniformity, right? And we discovered this in many different ways, also looking at more standardized approaches to care. So Jeremy, coming to you. So one thing that comes to mind, given the opportunity that digital solutions and remote medicine offer, thinking more, let's say, at the nature of healthcare services in most countries. You can think of it both developing and developed. One aspect that for me is important to note is that there is quite a bit of, let's say, protectionism, right? So healthcare services have a national framework. Think of accreditation of services, think about standards of safety and quality. Now you are an individual here based in a remote area like I am today, in Tamworth, which is northern part of New South Wales in Australia. Technically or technologically, I could contact a physician overseas, which through that interaction might basically tell me that I need X, Y, and Z follow-up services, right? So, but with that piece of paper, I do very little, right? I would have to see an equivalent physician, so there is application there, and so on and so forth, before I can access to the care that I already know I need, right? So what do you think this revolution means in terms of challenges for national systems or healthcare systems in general? And the first thing I can think of is indeed systems of accreditation, standards of quality and safety. What's your perception, Jeremy?
And thank you, Francesco. And a very good afternoon to all of you based in Asia. And Jacob, thank you for the presentation earlier. Can I offer a somewhat different, really contrarian view? I think the world will actually bifurcate into those where the medical councils and the governments become more and more protectionist and really clamp down on cross-border medicine, and the other side of the fence will be those where medicine becomes practiced more and more like accounting firms and law firms, where they go into partnerships, they go into really arrangements so that you can tap on the best expertise that a large firm has to offer across geographies, recognizing that for certain aspects which may be regulated, it's the same in with lawyers, with accountants, even in the really investment banking world, there are some professionals who can provide valuations and really so on, and some who cannot. And even beyond that, so I would see that as a first evolution, that the enterprising ones, they will form networks, much as what Joan's doing across the region. And the providers in the network will learn to trust each other, much like partners in a law firm across borders will learn to do, and they'll figure out that they are better together. And the rich people in the countries that close borders will basically figure out ways to seek almost all their healthcare outside. And in this day and age coming, I mean, honestly, it's not terribly difficult to send over a bunch of pills, right? Whether it is permissible or not, right? And if you look at what's happening in Indonesia, there are Singapore groups that hire a relatively junior, fully licensed Indonesian doctor who is basically paid to take risk, right? Where the Singapore-based doctor or the American-based doctor says you need drugs ABC, procedure XYZ, go and make it happen, and the local doctor basically carries out all this, right? Because they trust the doctors that they're working with and they are licensed. Moving forward, I would go beyond that to say that I do think healthcare will start to move more and more into capitation or really subscription type models. If we look at Kaiser Permanente, it has never been very successful in breaking out beyond the few areas within California, or rather within the US, California, a couple of other states, but Kaiser Permanente has not cracked the code in New York City, in Boston, and really so on. And I think times are changing for the reason that pretty much in the next 5 years, the doctor who doesn't work with an AI ML system in some way is just not going to be efficient enough in terms of number of patients seen, will not be practicing at a level high enough to be attractive to patients. And I'm reminded of this saying that we don't need to worry about the machines taking jobs from men, right? Machines will not take jobs from men. Men and machine will take away jobs from men without machine. And in the same way for really doctors, I would suspect that the doctor who still relies solely on what's between his or her 2 years is not going to be competitive very soon, right? And once you blur the lines between what is technology provided, what is human provided, then the traditional models of consults, time-based billings become very, very challenged. And I think Jakob spoke about how doctors will be burnt out being forever on call. But man and machine, like really Netflix never actually goes offline. Okay, seldom, yeah, but you can choose your movies and really so on. So that's where I see healthcare moving. But I recognize that I'm a very minority view in this, right? And of course, the economic models will change dramatically if the model of healthcare changes.
Thank you, Jeremy. That's very, very interesting. I mean, in linguistically, like what you said, or parts of what you said, it brings it nicely to what I had in mind in terms of asking Jacob, right? So you could see all this also as a question in terms of how healthcare systems will change. Of course, it's very hard to predict. But obviously one could observe that if we open the borders, which is the technology what in essence might do both from the demand side and the supply side, you may end up also in having more specialization, more differentiation, and actually platforms that facilitate comparative advantages, right? So I mean, Italy, for example, is great in primary care. I'm just making it up. So becomes famous for that. In a particular area, Australia in another area, rural health, for example, and then they become these global networks of, operating in a scale that certainly might drive many efficiencies. But certainly one might also argue that all this is very difficult to regulate, Jacob. And one of the aspects that for me is most striking is that if it would have been easier, we would have started to see not only the services, but also the question around insurance being dealt with in the digital space. And obviously that is a complexity that I haven't yet seen digital solutions for. Right, so and clearly you see these solutions in Uber, right, or other digital solutions that deal directly with the provision of the service itself, because the product is essentially very simple. But in healthcare, we know that, and you pointed out this very well, that you need an intermediary, a purchaser of services that knows what you're buying. So, and you mentioned this briefly before. So, what do you think the insurance response in terms of coordination of this enormous opportunity could be, and what would be the major issues in trying to create that coordination to have a level of scalability that is sufficiently attractive for, in fact, a purchaser of services to actually enter the space?
So actually, in relation to this, first of all, there is some legal issues. If you even take the United States, a doctor in Illinois cannot treat patients in other states. So, before we even go internationally, maybe the United States is an example, but of course there is a lot of legal issues, whether a doctor or a patient in one country can be treated, or what kind of treatment you can get in some other countries. But on the top of it, of course, I think the issue of insurance, I mean, I don't know. I'm not sure what will happen, but obviously, if you know, many countries have what we call national health insurance, one way or the other. So we have it in Israel, we have it in the UK, we have in many other countries. So the question is, for example, if you have a national healthcare system in one country, will it actually cover treatments by doctors, providers, even hospitals in other countries? And which is now much more of a possibility than it was, let's say, 10 or 15 years ago. So I don't know, it may mean also collaboration between healthcare systems in different countries. And in the same way, it's also really, as I mentioned, the reimbursement, how to pay doctors who work in other countries. So I think these are all really questions. I think that patients will require the option of seeing, so to speak, doctors in other countries or remote places. Because, if I'm a patient and I live in one place and I know there are great doctors or great providers somewhere else, then I may require it. And once the patients require it, the healthcare system and the insurance system will have to respond. If there is competition among insurers, and I'm an insurer in one place and I want people to choose me as the insurer, I will have to offer it. So I think once the option of remote medicine exists, the demand by patients will exist, and the demand by the patients to be insured for this treatment will come up. And then the insurers will have to respond to it. But as I said, there are a lot of legal issues, regulatory issues about it. And I think it's a challenge.
Thank you. Thank you, Jacob. Joan, do you observe in your particular area, or have you thought, or have you started thinking about more carefully about the provision of the services that you offer to the vulnerable groups, right? So even beyond the borders, I mean, something that you immediately think about it when you think about mental health, but not only. The ability to provide services remotely to communities that have a great demand but no actual service, nearby, and one could even think more in general about countries that are making an incredible transition from being purely developing to being more affluent and having resources. And as we know, the more rich a country becomes, the more the demand for health becomes important. But still there is a lack of a system in place where they are. So are you thinking about the issue of, let's say, the vulnerable, broadly speaking?
Absolutely. And thanks for bringing this up, though, because I think it's very important that, in all the hype and finesse of talking about digital health, that we have to recognize that there are limitations as well, and how do we work together to overcome that, because there are divides on several levels, I would say. So when we talk about vulnerable, you have vulnerable in a healthcare perspective, so a healthcare delivery divide where the access just simply does not exist in their vicinity, or even in the ecosystem that they're in. This could be people in rural areas. This could be people in even in urban areas, but perhaps just not in the socioeconomic class that allows them to engage as proactively as we would like. Or you also have the digital divide that happens, and it does not necessarily tie to socioeconomic means. I want to highlight this because you have emerging markets that leapfrog altogether. And most of them have phones before they actually do, mobile phones before they actually have anything else, before TV, before anything else. So it does not necessarily come hand in hand. And so I think when we think about how do we bridge these, for each different use case, for each different divide that we're tackling, we necessarily have to cater accordingly, right? So if, let's say, for example, we're talking about access to healthcare divide, that's something we're already doing. We're working very hard with our B2B partners. So whether or not it's in the form of employers, NGOs, or even pharmaceuticals and insurers, right? These are the ecosystem players, I would say, that are key to really bringing that access, to a wider spectrum. And of course, the healthcare providers are at the core of everything. When it comes to digital divides and socioeconomic divides, education divides, this is where I would say public-private partnerships have to happen in close tandem. Because this is not something that any one party can deal with. In the commercial world, it's a bit different, right? The insurers want to mark their territory, so boom, this is what I do. The pharmas, want to mark their territory for whichever drugs, or solutions that they're advocating for. But when it comes to these kind of issues of bridging divides, no one pharma, no one insurer, no one, vulnerable communities sometimes don't even have insurance in the first place. They have, whatever the government's giving, and that's about it. And so that's really where I think the private and public sector has to come in together. And that's really where there will be a sense of tension between, like what Jeremy mentioned, right? Those who are going down a pathway of closing up, and then those on a pathway that are opening up. And in that, we will have a different set of divides and vulnerabilities that will emerge, which we will then need to address, right? So I think that's probably in broad strokes, something that we are working very hard with, but it's an ecosystem approach.
Thank you, John. Now, Jeremy, I want to be in the last few minutes. I want to be sort of the devil advocate in a sense, right? So,
yeah, sure, happy to do that.
Yes. Yeah, there are some critics out there. They are looking at this with some skepticism, right? I know that you're very positive on this, and you've been incredibly active in the chat as well. But some critics, and again, of course, this is an industry that has a number of dimensions that are going in the direction of protectionism, right? So imagine just the local nature of this market and the existence of barrier in entry. So the idea of a monopoly, clearly each medical workforce in essence has that prerogative in its own countries. So if you open up, obviously prices will be affected and so on and so forth. So the bottom line of that criticism is that ultimately will be the decision of the supply side, so the medical professionals. And in fact, they predict that this will all blow over because they want to embrace it, they want to play this game, and so on. So what's your view on that? Is that something that you can really expect globally, or there are some signs for this not to be stopped, or if it is, that it's gonna basically, sort of fight back, or if you want, bite back? Thank you, Jeremy.
Thanks. I will make it very quick. There will be an eternal struggle with the combatants locked in a mortal existential challenge, because you're absolutely right. These are rice bowl issues. Medicine has been one of the most protected sectors for a very, very long time, because politicians are prepared to break rice bowls, but they're not prepared to play with people's lives. Right. And the medical profession has, we have traditionally scared politicians that doctors from overseas will provide poor care, people will die, and you will be responsible for lowering standards. And that's been a very effective argument for a long time. But if I look at private hire like Uber and Grab in this part of the world, I think things are starting to change. People are far more prepared to I won't say break rules, but to skate in where there are no rules. And it's fairly classic disruptive innovation, Christensen style. Where are folks playing? Joan is playing in the mental health space that has traditionally been unmet or underserved. Another area that's really bubbling up in this part of the world is in sexual health and femtech, right? And again, these are underserved areas, and you realize that the demographic or the market segment are those who are digital natives, those probably 35, 40 and under, and the folks who traditionally don't get good service from the incumbents, right? And basically the tide is in favor of digital transformations. It's a bit survivor-like. We old fogies will eventually die away. We will be replaced by the young fellows who will embrace this and have less concern about whether the service is provided out of Singapore, China, Australia, wherever, right? And we've seen that in every other sector. Why should healthcare be different permanently? Yes, change is hard in the healthcare sector, but I don't think change is just impossible. I think it's very, very possible.
All right, well, perfect way to come to our ending today. I really am very thankful to all our three panelists and for all of you who joined us. Thank you, Jacob. All the best with your travel plans, and certainly the same for Joan. Thank you for being pioneers, and definitely Jeremy to join us. I learned a lot today, and as much I think as our attendees who I invite to certainly contact us and be in touch with us through the Value in Health Economics and Policy group, and really watch this space in Singapore. As you see, we are really entering the space which is full of opportunities and important questions that will need everyone's help to try and be part of the solution. Thank you also, Professor Travaglione, for this opportunity to connect with us, and all the best of luck for you in the next few days, and we hope to welcome you in Australia very soon. And thank you, Rita, for your moderation and dealing with the questions. One last element for those that are here. We will soon publish this content as a video online, so it will be accessible certainly on VIP's website, and you are free to circulate it, so no need to ask us permission. This is material that is publicly available. This is our last event for the year, so we wish you all the best for the festivities, and please be safe. Thank you. Goodbye.
Thank you. Bye-bye.
Bye-bye.
Thank you, everybody.
Thank you. Bye.
Bye-bye.
Thank you.
Bye, Tony. Take care, mate.
Thank you, Francesco. Thank you.
Thank you, Rita.
Bye.